We now come to the backbench motion on the effect of the COVID-19 outbreak and the abolition of Public Health England on achieving a smoke-free England by 2030. Mary Kelly-Foy to move.
Thank you, Madam Deputy Speaker. I beg to move that this House welcomes the Government's ambition for England to be smoke-free by 2030, notes the increasing disparities in smoking rates between the richest and poorest in society, further notes the impact of COVID-19 and the opportunities and risks provided by the reorganisation of public health on our ability to achieve this ambition, and calls on the Government to set out further steps it has committed to take to deliver a smoke-free 2030. I'd like to thank the Backbench Business Committee for granting this debate, and I'm also grateful for every member who has given up their time to speak, especially the Honourable Member for Strangford. Oh, is he gone? Back. He's not back yet. Who I believe has already had 2 questions and a speech today, and I suspect that he still has an adjournment debate ahead of him. Madam Deputy Speaker, this debate is on an issue which is close to my heart, and I must declare an interest as a former chair of the Gateshead Tobacco Control Alliance. As the Prevention Green Paper acknowledged, achieving the smoke-free 2030 ambition will be challenging, especially in deprived communities where smoking rates are highest. On current progress, Cancer Research UK estimate these communities will not reach the 5% ambition until the mid-2040s. This is simply not acceptable. Indeed, in County Durham, adult smoking prevalence is 17% compared to the 13.9% nationally. This rises to 27% among people in routine and manual occupations. On top of this, 16.8% of mothers smoke during pregnancy, compared to 10.4% in England. Smokers in the North East lose around £600 million because of unemployment and reduced income due to smoking. For working smokers, weekly earnings are on average 6.8% lower than non-smokers, equivalent to £1,424 less per smoker annually. And this, of course, was prior to COVID-19, which is disproportionately harming the health of local economies of already disadvantaged areas. Helping smokers quit will benefit not just their health and well-being, but also their incomes, helping to level up disadvantaged communities. Smoking is also responsible for half the difference in life expectancy between the rich and the poor, and for every person who dies from smoking, another 30 are suffering from serious smoking-related diseases. Disturbingly, every week in England, almost 2,000 children take up smoking, 2/3 of whom will go on to become regular smokers. With 1,500 people dying from smoking-related diseases every week, there is no time to waste. The Tobacco Control Plan, published in 2017, was for 5 years, which comes to an end in 2022. It's already been overtaken by events and is no longer fit for purpose in the light of the ambition for England to be smoke-free by 2030, the decision to abolish Public Health England, and the Government's manifesto commitments to increase healthy life expectancy for 5 years by 2035 while narrowing inequalities. If a new tobacco control plan is to be put in place in a timely manner, it needs to be done and in development now. The Minister may remember that the last plan was published 2 years after its predecessor ran out of time. We need bold announcements from the Government on tough new measures along the lines set out in the roadmap to a smoke-free 2030, which has been endorsed by the All-Party Group on Smoking and Health, if we are to achieve a smoke-free 2030. So will the Minister confirm whether the Government is developing a new tobacco control plan, and if not, to consider doing so urgently? And will he further commit to publishing a new tobacco control plan in 2021, which will set out concrete measures delivering on the smoke-free 2030 ambition? Madam Deputy Speaker, Britain is a world leader in tobacco control, having driven down smoking rates by 60% since the start of this century. However, the Government's decision to abolish Public Health England without a clear plan for the future risks undermining this hard-won progress. The success in tobacco control has been driven by combining national population level interventions with comprehensive actions at regional and local levels. The national function is currently provided by a combination of the Department of Health and Social Care and by Public Health England. What is crucial is not where the function sits, but that it has protected funding and continues to exist. Furthermore, while inequalities in smoking rates remain, where regional tobacco control programmes have been in place, there's been a significantly higher rate of decline. Regional programmes, such as those led by Fresh in the North East, provide an effective bridge between national and local activity and between local authorities and the NHS. The government must publish a clear plan setting out the future of Public Health England's health improvement and wider functions. This is crucial if we are to achieve the government's interlocking pledges, not just to achieve a smoke-free 2030, but also to increase disability-free life years, reduce inequalities, improve mental health and reduce obesity and alcohol harm. Madam Deputy Speaker, the COVID-19 pandemic makes action to reduce smoking prevalence all the more urgent. Chronic diseases such as cardiovascular disease, respiratory diseases and diabetes amount for around 89% of all deaths in the UK and are also linked to higher rates of mortality from COVID-19. A robust and sustainable approach to health improvement is vital if we are to tackle the leading causes of chronic diseases, namely smoking, obesity and alcohol and drug abuse. However, the impact of smoking is not limited to the UK. It's estimated that at least 8 million deaths around the world every year are linked to tobacco, more than AIDS, tuberculosis and malaria combined. Over 80% of the more than 1 billion smokers in the world live in low and middle income countries. In addition to the human cost, the impact already on overstretched healthcare systems, this puts a heavy economic burden on these countries, all adding to the difficulties that LMICs face in recovering from the global pandemic. And that's why we can all be proud that the UK, as a global leader in tobacco control, is providing funding via the official development assistance to support implementation of the Framework Convention on Tobacco Control in low and middle income countries. The funding was £15 million over 5 years for the World Health Organisation's FCTC 2030 project to support low and middle income countries to implement tobacco control measures. The FCTC 2030 project has been very well regarded. However, funding is due to come to an end. Extending this funding will accelerate progress in ending the global tobacco epidemic, support FCTC 2030 beneficiary countries to recover from COVID-19 domestically, and, as the UK leaves the EU, maintain our position as a global leader on tobacco control. This is a matter of development funding, so requires broader support than just from the Department of Health and Social Care. But if the Minister were to support this proposal, it would greatly facilitate the likelihood of success. So will the Minister therefore commit to supporting extending the UK's funding for FCTC 2030 project beyond 2021? Aside from our international commitments, it's important that there is a focus within the UK at a regional and local authority level. Smokers from deprived communities with higher smoking rates tend to be more heavily addicted than those from more affluent communities. Deprived smokers are just as motivated to quit as other smokers, but it's harder to succeed when you're more addicted. Smoking is more commonplace and cheap illicit tobacco is widely available. Regional tobacco control programmes have been effective in tackling these disparities, as shown most clearly by the example of Fresh in the North East, which is the longest running and only surviving regional office for tobacco control. When Fresh was founded in 2005, smoking prevalence in the North East was much higher than the average for England, at 29% compared to 24% for England, and the disparity was growing. Since then, the North East has seen the greatest decline in smoking prevalence of any region, and smoking prevalence is now only a little higher than the England average. Smoking rates have also fallen faster among routine and manual workers in the North East compared to England as a whole. As a result, while the differential between routine and manual and professional workers declined in the North East between 2012 and 2017, it's increased in England as a whole. The success and value of Fresh's work is clear, and I would like to commend them for their vital work in the region. However, after the public health grant to local authorities was cut in 2015-16, the funding provided by local authorities for regional offices in the North West and South West was cut completely. Even in the North East, funding has been significantly reduced. New funding streams are therefore needed. In addition to this, there are stop smoking services which act as a highly effective and cost-effective way of supporting smokers to quit. However, there is stark inequity in the local authority offer to smokers across England. In some areas, stop smoking services have been scaled down or decommissioned altogether, while elsewhere, local authorities have sustained or developed their services. As ASH and Cancer Research UK report published in January, looking at the state of local stop smoking support, found that among the local authorities that still had a budget for stop smoking services, 35% had cut this budget between 2018-19 and 2019-20. This was the 5th successive year in which more than a third of local authorities had cut their stop smoking service budgets. Financial pressures due to the cuts to public health funding and the wider pressures on local government finances is the major reason for this. The public health grant, which funds local authority tobacco control, has been cut by around a fifth in real terms since 2015-16, fallen from £4 billion in 15-16 to £3.2 billion now. An analysis by the King's Fund in 2018 found that wider tobacco control and stop smoking services were amongst the biggest losers in terms of planned budget cuts. These cuts have been accompanied by a 38% decline in the number of smokers setting quit dates and stop smoking services since 2015. Among pregnant women, the number setting quit dates has fallen by a fifth. This is one of the many failures of austerity. So can the Minister confirm that the Government will reverse the cuts made to local public health budgets to ensure local authorities can play their part in delivering a smoke-free 2030? Madam Deputy Speaker, we must also recognise the value of social marketing campaigns which have immediate impact, can be targeted with precision at disadvantaged smokers and can be highly cost-effective if carried out at regional and national level. Such campaigns play a particularly important role in motivating smokers to try to quit. In 2016, Fresh worked with Smoke Free Yorkshire and the Humber to implement a hard-hitting quit smoking campaign aimed at raising smokers' awareness of the links between smoking and 16 types of cancer and trigger quit attempts, reaching millions of people. This is now thought to have been amongst the most successful quit campaigns to have ever been run in England in terms of awareness, attitudes and actions taken, with around 10% of people who saw it making a quit attempt. That's around 72,000 smokers. However, this regional activity is threatened by local authority budget cuts, which led to the decommissioning of the regional offices in the North West and South West. A smoke-free 2030 fund imposed on the tobacco industry, as proposed in the Green Paper consultation, would provide vital funding for national and regional anti-smoking mass media campaigns. Another important regional issue is the impact of illicit tobacco. This is concentrated in poorer communities, and cheap and illicit tobacco provides easier access to tobacco for children and reduces the incentive for adults to quit. In 2009, Fresh, along with colleagues in the North West and Yorkshire and the Humber, established North of England Tackling Illicit Tobacco for Better Health programme. originally with pump priming by Department of Health grant. The aim was to increase the health of the population by reducing smoking prevalence, by reducing the availability of illicit tobacco, therefore keeping real tobacco prices high, as well as by developing infrastructure to aid information sharing, identification of illicit markets and enforcement action. By reducing the demand for illicit tobacco through campaigns raising awareness of the issue and through engaging with relevant health and community workers. And finally, by regularly monitoring smokers' attitudes and behaviour to measure the effectiveness of the programme. Between 2009 and 2019, the illicit market share declined by a third in the North East, from 15% to 10%, and enforcement was enhanced. This compares to a national market share for illicit in 2018-19 for manufactured cigarettes and 34% for hand-rolled tobacco. Elements of the original North of England programme have been sustained by Fresh in the North East, including insight-led demand reduction programmes. Fresh now lead the National Illicit Tobacco Partnership, supported by ASH and other partners. However, the 2013 National Audit Office recommendation that this approach be rolled out nationally has not yet been adopted, while essential regional activity to tackle illicit tobacco and reduce smoking among young children and young people has been put at risk by cuts to public health grants since 2015-16. So can the Minister tell me if he agrees that the regional activity to get illicit tobacco off our streets should be sustainably funded? Finally, Madam Deputy Speaker, I'd like to raise the regulation review. While we await the Government's response to the Prevention Green Paper consultation, I hope the Minister may also tell us what has happened to the Government's response to the consultation on nicotine inhaling products regulations 2015, which closes in September last year. And a response to this consultation was due last December, and almost a year on, there's been no word from the Government about when this will be published. The Government is also required to review the Tobacco and Related Products Regulations 2016 and the Standardised Packaging of Tobacco Products Regulations 2015 by May 2021. The Government should set out the timetable for the consultation process for both sets of regulations as soon as possible. We are therefore currently awaiting the Government's response to 2 consultations and the launch of 2 more, which need to be reported by the end of the financial year. Can the Minister confirm when the Government will deliver on all 4 of these? I recognise I have posed a lot of questions, and I thank both the Minister and the House for their time. However, these are questions that need to be asked and answered if we are to achieve the smoke-free 2030 ambition that is shared right across the House.